Welcome to the LMHI Global Colloquium 2021. Today's theme are case reports, observational, pragmatic and randomized control trials. I would request Dr. George Matthew to please address the chairperson. We welcome our chairperson, Dr. Vipin Jain. And I would like to inform you, every speaker would get 15 minutes to speak. The timer would be, the clock timer would be on. I request you to complete your presentation on time so that others get to complete their presentation on time and we can even go with the question and answer round. Over to Dr. George Matthew.
Hope I am audible.
Yes, sir, you're audible.
So welcome all to this session. Today we have two respected chairs. Dr. Vipin Jain. He is the Principal and Director Academics, Professor and Head of the Department of Veterinary Medicine at M.L. Davale Memorial Homeopathic Institute, Palghar. And he has worked under the project of Homeopathic Management of Tuberculosis under the guidance of Dr. C.B. Jain, Honorable Assistant Director, Clinical Research at the Dr. M.L. Davale Homeopathic Medical Surgical Research Center, Malad East. And another contribution of his is he has organized and managed the anemia detection and treatment pilot research project for 125 tribal children in the tribal region of MLD Trust. So I take this opportunity to welcome Dr. Vipin Jain as chair for this session.
Thank you.
And
Thank you, Dr. George.
Another esteemed chair is Dr. Seema Rai. She is the principal of B.R. Sur Homeopathic Medical College and Research Center and also the professor of Veterinary Medica. Ma'am, welcome you to this session as chair.
So we shall start our program on case reports, observational, pragmatic, and randomized control trials. I call upon this first speaker, Professor Shyamal Kumar Mukherjee, to present his randomized control trial on the comparative study of 50 millisimal potencies and centesimal potencies in the treatment of tinea corporis. Welcome you, sir.
Oh, ma'am, first speaker we have with us is Professor Niranjan Mohanty, sir.
I think he is not on board.
Ma'am, he just joined actually.
So I may change.
We have sent him a request to join as a panelist. We're waiting for him to accept it.
Okay.
He's here. He's here, Dr. Anu.
Okay. So I request Professor Dr. Niranjan Mohanty to give us a speech on effects of individualized homeopathic medicaments in psoriasis, a single blind, simple randomized placebo control trial.
Dr. Mohanty?
Yes.
Yes.
Now I hope I'm there now.
Yes, so you're audible. We can even see you now.
It is now visible also.
Yes, visible also. We would request you to start with your presentation.
Oh, I have to start my presentation. Dr.
Yes.
Sharing. I have to share now. Allow me for sharing. My respect goes to the chairpersons and moderators and coordinators and all the delegates and my speakers, co-speakers of mine. So it is just a time of great opportunity. The premises of medicines, biological science and technology are greater than ever before. So now, if you see, I have seen that in psoriasis is a non-contagious chronic skin condition that produces plaques of thickened scaling skin. It is considered as an incurable long-term chronic inflammatory skin disease. Previous one. Psoriasis is estimated to affect 2 to 4% of populations of Western world. Commonly appears for the first time between the age of 15 to 25. And therefore, next, we in India, if you look to that, the prevalence varies from 0.44 to 2.8 and specific medical signs used for diagnosis are speech signs, Cobbler's phenomena, Candel's sign with itching. Pain localized in the papules and flex, as it was considered to be a chronic, intractable, and incurable disease. Hence, it was felt imperative to carry out a systematic constitutional treatment to validate the observations of earlier homeopathic and earlier homeopathic people's observation and the philosophy behind it. So we scanned here about 16 journals. So after that, we came to a conclusion that the primary objective is to study the response of homeopathic medicament in psoriasis with response to change in disease severity and change in quality of life of the people. So secondary objective was asserted of the relapse and recurrence of the psoriasis in patients during course of treatment. Then study hypothesis was formulated. In that null hypothesis, there was no response to disease severity in quality and quantity of the quality of life and increase in relapse and recurrence interval of the patient of psoriasis measured on identified parameter with homeopathic treatment. So the second was alternative hypothesis. So homeopathic treatment causes statistically significant improvement in disease severity and quality of life of patients suffering from psoriasis measured on identified parameters. So assessment parameters we fixed off. That's disease severity, and a measurement scale was psoriasis area and severity index, that is called PASI, which is in all hypotheses, usually it is pre-treatment PASI score is lesser than post-treatment of PASI score. And alternative hypothesis, pre-treatment PASI score is greater than post-treatment PASI score. So this was carried out in our International Study and Research Center on Homeopathy, and then there is a ethical committee of this institute. They approved that. Then we carried out the experimentations. Study duration was 2 years. Sample size was 90 per minute. 90 patients. Group 1 was centesimal potency. Group 2 was 15 potency. Group 3 was control with placebo. Then the sampling method we adopted a simple randomized method. We have 209 patients. Out of that, simple method of randomization was used to select 90 patients. In group 1 it was 30, group 2 30, group 3 was 30. So then we included the methodology we adopted. Inclusion criteria means age between 18 to 16 years we kept, gender, both genders was taken into account, case reporting with the plus, types of presence, all the symptoms of psoriasis were taken into account for the consideration of diagnosis of the purposes, including if there is a speech sign, Candle sign, and Cobbler's phenomena, we have to take into account. That was our exclusion criteria. Certain diseases like eczema, lichen planus, tinea, pityriasis, rosacea, and seborrheic dermatitis, and syphilitic psoriasis were excluded. Then treatment plan was constituted. So symptoms were collected in prescribed format, change in base of recording format, evaluated totality was built up by repertorizations, and then with consultation of the materia medica, it was prescribed. For repetition schedule, we repeated with the certain interval for centesimal scale, and that is 15 days, and for 50 millisimal scale, and nearly 4 days was the interval. So then we infrequent repetition we prescribe. That means then we follow up the case as per our score format. We had PASI score format, we had PDI format, we had RRI format. Accordingly, we follow up them, and in that outcome parameter we also fixed up. That is change in PASI and change in PDI, change in RRI. Secondary approach. Then results were documented. So we can see now. In the PASI result of centesimal, this lines we have got blue is control group, and the reds are centesimal. So always control is blue, red is drop. So here in the centesimal scale, we see that pre and post data were collected, and it was found almost all patients were improved except 3 or 4 patients. And similarly for the PASI, for 15 millisimal taken, there was no improvement for 3 cases, and all were improved. Similarly, result for placebo we taken with other comparison, there was no improvement except 2 patients who automatically relieved, because there's a 2 cases. So, however, this PDI also, this psoriatic disability index was taken into account, and then this blue is your control, red is. So then we observe there is also difference between them. 4 cases did not respond, other responded for this code. So here it is a group 2 before and during also. Then similarly for group 3 placebo here. So the recorded pre and post, and then we went for the RRI, relapse recurrence interval of the group. So here is the case we found that positive cases were 81.6 point and negative case was 18.33. So similarly for RRI group, the difference was the control group. There was 20% improvement positive case and 80% negative. So overall response of the result and medicine was taken into account. Thereafter, it was seen that it is 88% is positive and negative is 11.7 point. So result of RRI control group is so this is the overall response result of the control group. Only positive was 13 and negative was 86.7. So this was put to statistical analysis. So the computed value of this Kruskal-Wallis test was conducted to know whether it is a parametric or non-parametric. So this was seen that value was 22.91 and critical value of that critical value of this Kruskal-Wallis test was 5.9. So it is computed value similarly studied for PDI. It was 34. As much critical value was 5.9. So hence the null hypothesis was rejected. It implied there is significant difference between 3 values. So we went for p-value evaluations. P-value calculated value was 1.7 for group 1 and 2 comparison. So that is critical p-value was 0.8. So it is understood that it was medicine was significantly effective in the treatment of reducing the severity and area affected. Similar t-value for PASI group 3 calculated value and critical p-value is calculated value was 0.8 and our p-value was 0.3. So this shows that not statistically significant in the treatment of psoriasis, reducing the severity of affected area in the group 3. So similar paired t-test for PDI was conducted, and it was also similarly found it is significantly effective in the treatment of psoriasis and enhancing the quality of life. Similarly, for t-test for PDI was conducted for group 3, and it was found that not statistically significant in the treatment of psoriasis in enhancing the quality of life. Then for RRI group, chi-square test was conducted. It found that extremely statistically significant. Hence, medicine have able to increase relapse and recurrence interval. Chi-square test was conducted for RRI also in centesimal pretesimal potencies, and it was not statistically significant found. Means there is no much difference between 2 potencies. Similarly, overall response result of the medicine was studied in chi-square, and extremely statistical significance was found, and medicines are effective in the treatment of psoriasis is understood. So, in the conclusion, we concluded that the constitutional homeopathic medicines do act curatively. They should be the first line approach to treat the chronic intractable disease like psoriasis. And statistically established scientific wall and 50 millisimal scale of centesimal scales are equally important, conform to the subtle homeopathic philosophy, and frequent repetition is clue to the infrequent repetition is the clue to the treatment. So we can see this is the acknowledgement agreement stops here. You can see the patients that improve. Now you before and after is given here. This is one patient. Another patient you can see. Another patient you can see now. This is another patient before and after. before and after. You can see before and after so that you can convince yourself. So, let's see. Okay. See. Those are cure cases we have shown to you. They are very important. They very well improved. All diagnosed as psoriasis patient by our skin specialist. So my observations for future research to carry out further reference. That means homeopathy is in ample scope for treatment of these chronic intractable diseases. So I mean to say, 21st, this Hahnemann was not a solitary philosopher, plowing his only furrows. For the creation of all this, we all should be future researchers, should be future to find out the enhance, augment the cure rate of homeopathy in the treatment of psoriasis is my object. Thank you all. Now, questions can ask by my, can ask my questions. Okay.
Thank you, sir, for the wonderful presentation, very interesting presentation. I would now request Dr. Bipin Jain to ask questions and clarification regarding the same. Over to
Sir,
you.
good morning. A wonderful presentation. Listening to you after a long time.
Okay.
So, sir, there are a few things which I really want to understand as why did you choose centesimal and millisimal potency as a different group when that was not there in your objectives? So what was the thinking behind it?
Because we thought the potency we have not kept in view. The potency was free. So we thought, let us now, some cases we found aggravation in centesimal. So we, with that infrequent repetition also. So to start with this program, so immediately we shifted up to that, let us start 50 research scale. But unfortunately, our journey ended in fiasco. We could not find any difference between them. The only clue we could ascertain, the infrequent repetition is the clue to treat such disease.
So was there a difference between the aggravation setting in some cases in centesimal potency and millisimal potency?
So the aggravation means patient did not stick to our treatment when there was increased lesions, severity aside, and also the intensity of disability. Disability means they could not go to what they have in the field.
Because, sir, what has happened is you have taken a sample of 90 patients, and
Yes.
I hope that they have consistently there with you for 2 years.
Yes, they were.
So there were no dropouts from them, right?
No dropout.
And the other thing probably is that means, I mean, do we take further to explore that as far as outcome is concerned, there is no difference between either you use centesimal potency or millisimal potency. But is there a guideline which could have been evolved that which are the cases more suited for millisimal potency and which are the cases more suited?
No, that we could not arrive at any conclusion there.
Okay, sir. Thank you. The other thing, how did you, took care of the type of psoriasis while doing the sampling?
That we have not earmarked them. We have reports, but we are not, because in the primary objective, as you told, we have not kept them as secondary objective.
So was there that
record will say also retrospectively, we can evolve that also.
Because what I'm saying is, sir, psoriasis severity index, was there almost similar in all the three groups?
Yes, that is a format, same format used for the three groups.
No. While doing sampling and after doing the analysis, was the PSI index was same in all the three groups or similar, not much variable?
Same people, same format.
So since you have not taken a care of, it was not possible to classify the psoriasis and put them into a group by stratifying them. This was an important observation.
This is an important aspect. Future researcher can undertake this, I feel.
And And how do we, I mean, what is your observation that how long one should wait for the relapse or reappearance of
Relapse
psoriasis
was,
under homeopathy?
suppose a relapse was 1 month interval, that has increased in 6 months, 9 months, like that.
Okay.
So it is not constant in all cases. It was variable for all type of different type of people, different cases.
Mm-hmm. And what was your, sir, observation of response to the treatment? You know, how long and which were the symptoms which disappeared first, or what relief, and then what was?
In disappears also in the last or second month. If it is not there, it will not improve.
So which were the symptoms which started, you know, with the 90 sample or 60 sample on homeopathy, which started disappearing first?
Itching disappears first.
Good, sir. Thank you, sir. So that clarifies a lot of, and it was really wonderful listening to the.
Thank you, Dr. Johnny.
Yeah, Dr. Matthew, anything else? Madam is not there?
Sir, ma'am has not joined yet.
Yeah, ma'am has not joined. So
Okay.
Yeah, we can go over to the next presentation.
Yeah.
Thank you, Dr. Mohanty and Dr. Bipin. Now I call upon our next speaker, Dr. Abdul Rahman Sheikh, to present the study on efficacy of individualized homeopathic medicine in the treatment of atopic dermatitis in adults, a double-blind, randomized, placebo-controlled preliminary trial. Over to you, sir.
Okay. Hello, everyone. Myself, Dr. Abdul Rahman Sheikh, house staff of DND Homeopathic Medical College and Hospital in West Bengal. Speaking upon the paper entitled Efficacy of Individualized Homeopathic Medicines in Treatment of Atopic Dermatitis in Adults, a double-blind, randomized, placebo-controlled trial. The study project was carried out under the STSH scheme 2018 of CCRH in India, under the guidance of Dr. Shomit Der, and the paper was published in the research. Paper was published in the journal Complementary Medicine Research on April 2021, and this is the first page of the article. And the published paper was also indexed in the PubMed. Atopic dermatitis is a chronic relapsing pruritic inflammatory skin disease having significant impact on the quality of life and public health cost. Prevalence of atopic dermatitis in worldwide is 1 to 3%, whereas in India it is 23% and is the 8th skin disease among the top 50 most prevalent diseases globally, resulting in disability adjusted life years loss. Atopic dermatitis presents with manifestations such as itch that leads to excoriation and lichenification, dry skin, atopic eczema. As per the United Kingdom diagnostic criteria for atopic dermatitis, patient must have an itchy skin condition or parental report of scratching or rubbing in a person, plus 3 or more of the following: history of the flexural involvement, antecubital or popliteal fossa, front of ankles, wrist or neck, visible flexural dermatitis, personal history of the asthma or hay fever, or history of the atopic disease in the parents or sibling if the patient is younger than 4 years of the age, history of generally dry skin in the last year, onset under the age of the 2 years. Atopic in homeopathy, it is believed to be atopic in treatment of the atopic dermatitis is effective, but no conclusive research evidence revealing the real efficacy of the homeopathy in atopic dermatitis is still inadequate. A 4-arm feasible RCT was conducted on 75 adult patients suffering from atopic dermatitis. No outcome measures show statistically significant changes in either of the groups. 2 non-randomized trial comparative studies seem to suggest therapeutic equivalent between homeopathy and conventional therapy. Yet both were open to selection and other biases. 3 observational studies were also carried out reporting positive results favoring homeopathy, but there were obvious methodological constraints. Thus, this RCT was aimed at assessing whether there was a difference, alternative hypothesis, or no differences in null hypothesis between individualized homeopathy and placebo in the treatment of atopic dermatitis. The aims and objective of the study was to compare the efficacy of individualized homeopathic medicines beyond placebo in treatment of atopic dermatitis in adults, to compare the changes in the patient-oriented score of atopic dermatitis, dermatological life quality index, and atopic dermatitis burden scale for adults scored between the two groups, and also to shortlist the frequently indicated homeopathic medicine for atopic dermatitis. A double-blind randomized placebo-controlled parallel two-arm clinical trial study design was adopted at the outpatient department of the Dean Homeopathic Medical College and Hospital, West Bengal. Atopic dermatitis patients were included as per the UK diagnostic criteria for atopic dermatitis and PO scored more than 10, literate patient of age 18 to 65 years, both sexes, and patient already undergoing treatment of atopic dermatitis may be recruited on completely stopping the medicine after a washout of 1 month. Patient, those are too sick for consultation, unable, unstable, or psychiatric illness affecting quality of life, substances abuse or dependencies, pregnant and lactating women undergoing homeopathic treatment for any chronic disease within last 6 months were excluded. Regarding the sample size, we aim to achieve a small sample size of the 60, 30 in each arm, that is only feasible at a short stipulated time period of 6 months only. A permuted block randomization method was done by SPSS generated random sequences version 20. For the intervention, the study being RCT on experimental arm was indicated homeopathic medicine and the other comparator arm was the placebo. Medicines and placebo procured from the GMP certified company and were repacked in identical glass bottles and labeled with the potency, name of the medicine, and coded. Medicines were dispensed according to the randomization list. All the outcomes were measured monthly for 3 consecutive months, and the primary outcome were measured by the PO scorer, and the secondary outcome were measured by the DLQI and ADVS scale. Statistical analysis carried out on intention to treat approach method, and the missing values were adjusted by the last observation carried forward method. Baseline differences were adjusted by the covariant models, and the group differences were also tested by the unpaired t-test. The protocol was approved by the IEC prior to the initiation, and the study was also registered in the Clinical Trial Registry of India. Regarding the consort study flow diagram, atopic dermatitis, 81 patients suffering from the atopic dermatitis were screened, 21 were excluded on account of the various reasons, 60 patients were meet eligibility criteria, enrolled and randomized. 30 in each arm, 30 received the individualized homeopathic medicine and 30 received placebo. 9 patients were dropped out, 3 from the individualized homeopathic group and 6 from the placebo group. All the randomized patients entered into the final analysis. Baseline group differences were non-significant as the baseline data, age, socioeconomic status were adjusted by the ANCOVA model. All the group differences were higher, favoring homeopathy over the placebo, though the study was statistically non-significant. 20 different medicine frequently used: sulfur, natrum muriaticum, natrum sulfuricum, belladonna, and Ras toxicodendron. The most frequently medicine was sulfur. Thus, the study atopic dermatitis identified a clear trend of improvement beyond placebo. Double-blind and randomized design and repeatedly measure data on validated outcome measures, consort and red hot guideline style for reporting, intention to treat analysis. The choice of the individualized homeopathic medicine was the strength of the study, and the study limitation of the study was inadequate time. A longer follow-up might have been more beneficial, and the future in future longer follow-up are warranted. Taking up objective like the serum IG might be another fruitful venture, and the trial being underpowered and of the short duration, no definite conclusion regarding the efficacy of medicines in atopic dermatitis can be arrived, and cautious interpretation of the trial finding is necessary. And this is the last but not the least, our great poet Rabindranath Tagore also emphasized on the research on homeopathy. Thank you.
Thank you, Dr. Abdul Rahman, for your excellent presentation of the RCT done. I now request the chair, Dr. Bipin Jain, for his comments and questions.
Very good presentation, but there are definitely some questions. Why it was, limited time frame was taken? What was the compulsion? Because that is not serving the purpose of what we want to show. So, what was the compulsion?
Actually, sir, this study was this study protocol was conducted on the STSH program of CCRH, and there was a time limitation of 6 months only, and for that reason we choose that time period.
So then what was the compulsion of choosing atopic dermatitis when it is difficult to, when you are taken a cases of minimum 10-year duration, then there are a lot of variables, because individualized homeopathic medicine choosing at one go. I mean, I have to yet to see the people who are always successful in choosing a right remedy on the first, even the greatest. So because everybody has got the failure. So how did you take care of that? Because otherwise, yeah, go ahead. Yeah.
Actually, sir, in our OPD, a lot of patients are coming with the atopic dermatitis, and this is a very burden for this society around my college. And for this, we choose this as a project.
No, because we are trying to conclude against placebo and the individualized homeopathic medicine. So to conclude and to publish, I mean, it is not doing the type of service your project would have given to the homeopathic fraternity. Because the time period is less, only 3 follow-up, number one, and that also monthly interval. So, I mean, you have no time even to change, and probably even your reputations and the potency selections, they have also not got reflected to help to understand the processes. So, I mean, it's a good project. The only thing was time frame and taking care of variables of prescriptions, because when you are treating a disease like atopy, there are a lot of chances of aggravation setting in. So, it becomes difficult even to differentiate sometimes whether it is a disease aggravation or, our remedy is doing some mischief there. And since the time frame was less and you have chosen a 10-year minimum duration, it doesn't match. So I thought you were trying to do some magic with homeopathy, and 3 months everything will disappear.
No, sir. Actually, we were tried how much improvement was, is there any improvement is going or not?
And because since it is a 10-month duration, the severity score, the extension, the relapse, the aggravating. So if you have a winter aggravation of some atopy, and
yes,
if you
sir,
choose our different people will have different aggravation season, aggravation time. So, all those variables then defeats the purpose of outcome until you have one whole cycle of a year at least.
Actually, sir, this was a preliminary trial, and in our college also there is a larger trial is ongoing.
Very good. So you must, take care of all this. And
Yes, sir, yes,
only
sir.
one question: why literate patient? I mean, what was the reason for literate patient?
Sir, atopic dermatitis burden scale for adult scale was filled only by the patient himself and not by the physician or others. Only it is
I
filled
mean,
by
you can have an unbiased person who is sitting and taking up the things.
Yes, sir. Yes, sir. Yes, sir. It is all the patients only feel the patient was unbiased. Whether he is taking the medicines or placebo, and
No. What I'm saying is the scale which you thought that only literate person will be able to fill.
Yes, sir.
Yeah, so even somebody who is unbiased can ask questions to the patient and can fill up the form.
Must be filled up by the patient.
Acha, okay. So it becomes difficult again, to exclude that. So that doesn't say that it was the reason for exclusion. So good. I mean, this is a very good beginning. We will wait for a larger trial with a longer duration.
Yes, sir. We are doing this.
Yes. So take care of all other variables. I think it will be a wonderful service to homeopathy in time to come. Thank you.
Okay, sir. Thank you, sir.
Thank you, sir, for your wonderful comments and the appreciation and the focus on what should be done. Thank you.
Now we have Dr. Chintamani Nayak to give his presentation on effectiveness of individualized homeopathic medicine and Urtica urens mother tincture in the treatment of hyperuricemia, an open randomized pragmatic trial.
And thank you, sir. I welcome to all the delegates, the chairperson, Dr. Bipin Jain, Dr. George Matthews, moderator, and all the moderators present in this forum. Today, it is the occasion where we are going to present ourselves only for the commemorating the LMHI 2020-21. Sir, it is my topic today. It is the topic where it has been the study has been carried out. This is the topic is about effectiveness of individualized homeopathic medicine and Urtica urens mother tincture in treatment of hyperuricemia. And this is a RCT, open RCT that and an open randomized pragmatic trial, and this was carried out by in the NIH and National Institute of Homeopathy, Kolkata, and all the contributors' name are there here. So I'll be why this topic was taken. The most important thing that why we took the topic about hyperuricemia. This is not a disease. This is only the elevated level of uric acid level, and all the patients coming to the OPD. When we carried out the investigations are going on, and we saw the reports that many of the patients are having uric acid level high. So, in order to know what is the why it is happening, so we wanted to introduce certain remedies that are included in the Mater Medica. And when you went through the portal, different portals for the collection, we took some medicines to be collected where it has not been, the study has not been carried out. We found many medicines like colchicum, brania, lidampal there, and the study was being done. So in order to exclude that, we took a new drug, that is Urtica urens. And why Urtica urens mother tincture was also taken, that was because when you go through our source book, it has been mentioned that in Urtica urens, only 2 patients have been treated, and it has been given the name especially suited to uric acid diathesis. So that in order to make a primary impact upon the society, why it should not be the baseline for the scientific society that yes, urticaria is the useful also in dealing with the cases of hyperuricemia. So in that way, I try to manage to take this topic, hyperuricemia, particularly involving the urticarians. And in this case, it was we wanted to make it in a three-arm trial. One is we included, that is individualized homeopathy, along with another was only urticarians mother tincture, and other was both individualized homeopathic medicines as well as urticarian mother tincture. And we took this study was done for over a period of 1 year, and 90 patients sample were collected. More samples were collected, but 90 patients are taken in this study. And the hypothesis was that there is no difference in change of serum uric acid level among the individualized homeopathic medicines as well as urticaria and mother tincture, and both individualized homeopathic medicine as well as urticaria and mother tincture over a period of 6 months of intervention. So in that way, we carried out an alternative hypothesis was we also took, that is there is some significant differences. And with the aim that we wanted to evaluate the effectiveness of these three arms, whether they are able to help in changing the serum uric acid level or not. That was our main aim. And in order to achieve our aim, we wanted, took some objectives. That was the first, only the one main primary objective was that to compare the changes in the symptom severity level and quality of life scores among the three groups. We took mainly GAQ assessment score, that is as well as MIMOC. We have to, and the study design was open label, randomized 3 parallel arm, pragmatic trial. And the study setting, we made it in National Institute of Homeopathy, Kolkata. The material and methods, the study population, the patients who are attending the OPDs of NIH, and as I told before, that is the period of study was for 1 year. And the individual subjects were studied for 24 weeks, that is 6 months. And we took the, before this was in front of the ethical committee, it was being put with the calculation of the sample size, and we got the effective size was 0.47 with an alpha error that is 0.05. That means we are 95% confident that, and the power beta was 90%. And inclusion criteria, the patient suffering from hyperuricemia with or without gout, because we didn't exclude anything. Whatever the whenever the uric acid level is found, we have taken. And the inclusion criteria, what I was telling, that the patient suffering from hyperuricemia with or without gout, and the age was because we fixed the age between 18 to 65 years. We didn't include above that, particularly the known but controlled systematic diseases with medication also we have taken. Those cases were enrolled also, and we took the informed consent of all the patients. And in the exclusion criteria, if any complication that it is there, particularly secondary gout, we didn't include those cases. Psychiatric cases we didn't include, or any life-threatening cases we didn't include, or any substance abuse is there. Pregnant women and lactating mothers were not been included in our study. So the main outcome measures what we have taken, that is, I have told you before, that is the gout assessment question score we have taken, and we have translated because all are from Kolkata. We made it translated into Bengali version, and the patient has to feel also if any difficulty they are facing, some other persons will be helping out. And another is my mob. Measure yourself medical outcome profile was being used for this outcome map. And the timelines we fixed, that is minimum the 3 follow-ups are to be there with a that is baseline. It will be there 3 months and 6 months, and the statistical analysis, because we have to include before and after test you have to do. So the paired test have been and there is comparison of all the groups, so another test was being included in this. And the study flow, according to the RCT protocol, we have to follow this study flow, and we included 146 patients and in the study while screening, and after that near about 66 cases were being excluded out, and 90 patients are being enrolled in 3 arms, that is 30-30-30, and in after 3 months there was a dropout also, that is lost to the follow-up. It was there in that is individualized homeopathy. We have lost the 3 cases, and in case of urticaria mother tincture, 22 patients are being lost, and whereas in both the individualized as well as urticaria mother tincture, we have 2 also. So in that way, what our intention was to, at the end of the study period, we have to follow the ITT, the intention to treat analysis. We have to take all the cases, and that has been included. So in that way, we managed to take all the study, all the parameters what we have taken, included in that. And the results, what we found that these are the line diagrams of all the treatment changes that has been found in 3 groups over 3 months and 6 months of time. In that, it is found that in this particular group, we'll be finding that the mother tincture showed that red line that is being there showed much more improvement in this 3 months of time, whereas afterwards individualized homeopathy medicine as well as mother tincture, there is some difference. But in every aspect, we found that medicines are acting. Also, the GIQ assessments questionnaire also showed the improvement in the mother tincture in the 3rd month of, also, as well as in 6 months also there was certain significant changes. And at the end of the 6 months also, we tried to manage, and there is certain differences we found out while going for the 6 months. There is a little bit changes it was found in case of individualized homeopathic medicine as well as mother tincture. There is rapid improvement at the end. That means it showed that both individualized homeopathic medicine and mother tincture are helping out much more. So beforehand, it is in our mind, it was there that we wanted to know whether urticarians mother tincture are having certain important features of decreasing the uric acid level or not, and it was confirmed that the urticarian mother tincture is also helping, and that will be mother tincture. Again, we can in the future studies we can take the potencies, and we can study whether they are able to help us out or not. And the prescribed medicines, what we found in individualized homeopathic medicine group. That was mainly the colchicum was the first medicine. Second, Ledempal, Lycopodium was the third, Bryna was the fourth. There was much more, they are helping out. All these medicines are also found to be important while dealing. And in individualized homeopathic medicine plus Artica mother, along with Artica mother tincture also, we found that Colchicum autumnale was also, that means it shows that Colchicum autumnale is also having certain what previous studies they have done, that is also being reflected, that Colchicum autumnale is also helping out in decreasing the uric acid level. Along with this, Ledempal also. Along with that, Artica mother tincture is also helping in reducing much more. That was the most important aspect. Whereas in Bryna was not found to be in individual homeopathic medicine as well as Artica benzoic acid came into the fourth place. That was the observation. So this, the strength of our study was that we took the sound method, that is the RCT we have taken, and in that we took our intention was to treat the patient and we have to come to a valid outcome, and it was successful. Our result was somewhat good for us, and so the limitation was even if it is for 1 year duration, if we cannot take, but a large sample size can be taken for this study, and it is being carried out also in our institute for future purposes, we're including much more patients also. So this is a large sample size you have taken, and we are going to find it out again. What will be the most the outcome measures will be studied out and will be publishing also again. Then in conclusion, what I found out in this study, it was that individualized homeopathic medicine showed significant changes in the intensity of the symptoms of the patient and well-being score, whereas after 6 months, individualized homeopathic medicine as well as Artica urine mother tincture was found to be more effective than individualized homeopathic medicines or Artica urine mother alone, especially in the domains of MIMF scale. These results suggested that the individualized homeopathic medicines along with Artica urine mother tincture can produce additional advantage. And this advantage can be, we can utilize it by using the potency decimal scale or centesimal scale potency medicines we can use, and we can find it out. Because as mother tincture is it is in physiological dose, every time we cannot use all these medicines. So potency, this will be the baseline where Artica urine mother tincture will be the baseline for the future studies. And this was this publication was we have generated this publication in JCM, and in 2020 it was published, and after that we are having this DOI there, and at last, thank you, sir, for this all the painful as well as for the future studies what has been going on, we are presenting here, and it will be also more effective through this forum only. All this presentation will be more effective in this forum for the future studies also. Thank you, sir.
Thank you, Dr. Chintamani Naik, for your interesting study and presentation. I would now request Dr. Bibin Jain to give his comments and clarification.
Good morning, Dr. Chintamani.
Good morning, sir.
Yeah. See, there are few things which I want to clarify. You said
Yes.
hyperuricemia with symptoms or without symptoms, because if the symptom develops, then we do diagnose as a gout.
Yes, sir. Mainly we took the symptom without any symptoms. We took whatever the cases are coming in our OPD and any cases which are coming for any symptomatic cases. Any symptoms they are coming when we are finding out that uric acid is level high, we are including that one. That was the main criteria.
Because
And sometimes the pain was mainly the joint pain, all these things were there.
So then it falls into category of gout.
Yes, yes, sir. But gout was not diagnosed.
Why with the hyperuricemia and with the symptoms of the joint swelling,
yes,
pain? So that was one thing, and then also you have used a scale with the symptomatology.
Yes, sir.
So if so, then what is that scale?
The pain assessment scale, sir. In my mock, that is the pain assessment. Pain assessment will be there. The patient will be complaining.
So that is where. Correct. So what? Sorry to interrupt. That is where I want you to differentiate that what is hyperuricemia and what is gout, and how did you classify them? Because that is not becoming clear.
Yes, sir. I will be telling, sir. Whenever the cases were coming with pain, and we sent for the laboratory investigations, and we found, and particularly in gout feature, the grade 2 should be inflamed. All these things should be there.
No, not necessary. Always that is the diagnostic criteria.
Yes, sir. That is there. But, for gout also we did other test, that is trophy exclusion, and that is our urate crystals, all this, even if aspiration of from the joints also, many patients are coming from outside. That is being treated from outside, they are coming. In that, they are not, excluded gout.
So it's a very thin line before the diathesis become a complete disease. So I mean, it was little confusing at that level. So if there's a clear delineation and line is being put, that will help further defining. The second thing was, how did you take care of diet, nutrition, and lifestyle changes? Because if you understand the disease, it's a lifestyle disease primarily. It is being said that it is the disease of rich people.
Yes, sir. We excluded all these things. Diet also, whenever any uric acid level is high, we excluded the protein diets. Mainly the protein diets are being excluded.
So how did you take the care whether the fall in uric acid was because of, you are taking care of diet, nutrition, and lifestyle changes, or it was because of the individualized homeopathic intervention?
Sir, along with that, every patients are being included wherever, whether it is individualized homeopathy medicine or everybody we are giving same features are given. So
okay, thank you. Yeah, so that means everybody was given an advice for diet, nutrition, and lifestyle changes.
Yes,
so there was no variations at that level. Yeah. There are few antihypertensive drugs which are known to increase the level of uric acid. So have you taken care for inclusion and exclusion criteria there? Because I am not seeing that as one of the criteria.
Yes, sir. Particularly the hypertension, we have excluded out those who are, but I have written that systematic diseases are in that. Suppose a person is having malignant hypertension.
No. I am not saying, sir, that. What I'm saying is the diuretics, the beta blockers, the alpha-1 blockers, which are used for hypertension treatment, frequently they are known to increase the uric acid level as one of the side effects. So have you taken a care of in a exclusion criteria?
Yes, sir. That has been taken into account because we didn't include the particularly those who are under medication, but under nitrates, particularly the nitrates.
So that is I am not seeing in your exclusion criteria. So please add that, because that will give you the more scientificity. And I feel that your observation period should be at least 2 years duration and not 3 months to 6 months.
Sir, it is
So
being
it's a
carried out.
systemic metabolic disorder which is
Yes, sir.
influenced by so many factors.
Yes,
And
sir.
with the individualized homeopathic treatment, if we take such an early, or even the role of mother tincture.
Yes.
So, if you further take up the study that
Sir,
which
that
were the
has been
cases
taken
more.
also, sir.
Okay.
This study is being carried out because it has not been finished also.
So have you come to the conclusion at somewhere that which are the cases which are more suitable for mother tincture and which are the cases more suitable for individualized homeopathic treatment?
Sir, this is the reason what I wanted to tell from the beginning, that mother tinctures, whenever we put it in the ethical committee about mother tincture, there is a question. There is a question that arises: why mother tinctures you are taking? That means physiological doses. These are the physiological doses. Why you are going to include? Because until and unless you create a baseline, so urticarians potency now it can be studied out. Baseline
my question is little different, sir. What I'm trying to say, understand is, and I also want to learn that which are the cases more suited for mother tincture and which are the cases which are more suited for individualized homeopathic treatment based on your assessment of susceptibility or the state of the disease.
Sir, here
is there any study done?
Sir, here actually what happened, according to our RCT, that because we have made it all the randomized, so we cannot whatever number was suited, we are not able to think that to which patient we are going to, because to our pharmacy that has been taken into account. So I can that is also, if it will be a longer period, we can study that thing also.
Okay, thank you. Wonderful thing. Please continue, because this is one of the most important and the growing illness which is diagnosed late many times, and it can have a damaging effect on not only on the joints but important organs of the body. So this can be a path showing things. Thanks.
Thank you, sir.
Thank you. Thank you, Dr. Bipin, and thank you, Dr. Chintamani. Dr. Bipin, especially for clarifying the forward progress of the study, and thanks a lot.
Now I invite our next speaker, Dr. Nitin Saklani, to give us presentation on individualized homeopathic medicine in the treatment of generalized anxiety disorder, a double-blind, randomized, placebo-controlled pilot trial. Over to you, Dr. Nitin.
So, morning greeting to everyone. I basically came here to present this particular presentation over individualized homeopathy in the treatment of generalized anxiety disorder, a double-blind, randomized, placebo-controlled, and pilot trial. So the main author is basically Manish Pareva. I belong to the core team of this particular research project. So I am presenting on behalf of him. So let's just proceed forward. This is the first page, as this is published in Complementary Medicine Research Journal, which is in PubMed Index journal. So the quality of this particular paper you can yourself understand, because it is published in one of the international journal. So it is quality-wise one of the good paper that is published. So we proceed further. First of all, let us introduce over this that why author and the core team choose this generalized anxiety disorder as a topic of research. So in spite of various claims done by the various homeopaths, those who are dealing with the anxiety related disorder, still the role of homeopathy is completely anecdotal and it's story based. So there is no documentary evidence till that when we are performing this particular trial in National Institute of Homeopathy. So we did not find any significant, even with the extensive search over the journals, e-journals, we only found that there is 8 RCTs are conducted and 1 uncontrolled trial is there, and 3 case series are published which are claiming that there is a role of homeopathy in dealing with anxiety disorders. Earlier we also tried a systematic review to be done over this, but nothing can conclusive will be done because of some methodological issues with these all RCTs and uncontrolled trial that is published. Only two trials we found. One is GAD Bonet et al. And Thompson et al. These two trials are basically found who having a methodologically correct, completely correct. And these can be took up as a ground for doing this particular project. We did a PICO intervention analysis, that is we compare these trials on the basis of patient intervention, comparator group, or outcome assessment parameters. So nothing we will found out that which can resembles to our study designs. So because of that, what will happen, we could not be able to perform a definitive trial that is based on some statistical parameters. So initially we thought that we should run some external pilot trial. So for an external pilot trial, we consider that an effect size of 0.2 is significant. But this, if we cap this effect size of 0.2, so it really gives us a very huge number of 800 patients to be done in this. So definitive trials are not possible because it's a post-graduation thesis project. We consider that 8 to 10% is a significant number of 800 that can be justifiable for doing external pilot trials. So this leads us to perform a double-blind RCT external pilot trial on generalized anxiety disorder. Now, the materials and method, as the study design itself, it is mentioned it's a double-blind, 2 parallel arm, and pilot RCTs. And for screening purpose, we use GAD2 screening. If the subjects who is suffering from generalized anxiety disorder and they score higher than 3 or 3, in GAD we include them in the study, and we perform their screening further or the assessment of anxiety in relation to GAD-7 score and Hamilton anxiety rating scales. So these are the two assessment outcome assessment measures which we use in our study. One is GAD, which is GAD-7, that is a primary outcome assessment, and Hamilton anxiety rating scale, that is a secondary outcome. So inclusion criteria for this particular study is we consider moderate and severe categories. Moderate and severe category, we refuses the mild and very severe category of generalized anxiety disorder. In terms of our outcome assessment measure, if we talk about the GAD-7 score, if it lies in between 10 to 15, we include the case. If the Hamilton anxiety rating score lies in between 18 to 30, we include these cases, both males and female, and the person who is belonging to 18 to 65 years, and patient willing to participate in a clinical study is our inclusion criteria. Now, exclusion criteria, as I already mentioned, the mild cases and very severe varieties of generalized anxiety disorder, we excluded these cases. So in terms of our outcome assessment measure, if GAD-7 score is less than 10 and Hamilton anxiety rating scale is less than 18, then we excluded the case. And if it is a very severe where GAD-7 score is more than 15 and Hamilton anxiety rating scale is more than 30, which are considered as very severe varieties, we excluded these patients. And some of the patients who are taking any kind of TCA, tricyclic acid, SSRI or SNRI, we excluded these cases, except some psychotropic drugs like zolidipine, which is used commonly for the sleep purpose. And some of the cases who are self-reported in pregnant women, we excluded. Our primary outcome for the studies, as I already mentioned, GAD-7 is our primary outcome assessment measure. And Hamilton anxiety rating scale is our secondary outcome assessment measure. So this GAD-7 is basically self-administrative, psychometrically valid tool. It's a patient-based tool, so patient need to fill itself. And the Hamilton anxiety rating scale is basically a physician-administrated. Some psychiatrist will evaluate the symptoms of a person who is suffering from your generalized anxiety disorder. Now, the third slide of my material and methods, as it's a postgraduate thesis. So it is done in our National Institute of Homeopathy. The sample size, as I already said, that it is an external pilot trial. So there is no justification required for the sample size, but we kept formal effect size of 0.2. and 8 to 10% of that 800 sample size, we kept that it is sufficient to do some preliminary studies over that, and that comes under near about 62 is a justifiable this sample size for running this external pilot trial. So randomization is done, permuted block of variable size 1:1 allocation is done, and it's a double blind trial. Allocation concealment is there, identically coded vials are there, 1:1 statistical method because it's a baseline and after pre-intervention and post-intervention assessment at the baseline and after 3 months. So that's why unpaired t-test is used by using SPSS or statistical software to know the results about that. Ethical approval is also taken, and CTI registration number is also mentioned here. The trial reporting is based on consort guideline, which is given for randomized controlled trials, and red hot guidelines, which is for the homeopathic randomized controlled trial. And this trial reporting is also based on MVHT, that is model validity of homeopathic treatment, which is given by Robert Matthey, which shows the homeopathicity of the prescriptions. So that these trial is basically based on all these reporting guidelines. Now our next is this is the result section which we will discuss. This is a basically participant flow. We screen out near about 111 patients, and out of that 49 patients are excluded due to some reasons. Some were having severe anxieties, some were on medication, someone having some psychiatric diagnosis, other psychiatric diagnosis, some is having a hyperthyroidism, substance abuse, uncontrolled hypertension, and diabetes. With only 62 people we found out they met with our eligibility criteria, in which randomly they are placing into two groups. One is individualized homeopathy plus counseling, and second one is placebo plus individualized plus counseling. So 31 people are taken up. Only three subjects in both the groups they does not completed with their follow up, so they discontinue. But because we earlier we thought that we will do the intention to treat analysis approach rather than per protocol, so we included both in both the group. We included the three patients also in the result section also while we are interpreting our results. So this is a comparable. This is the baseline assessment of both the groups, whether the person is coming into the individualized homeopathic group, whether the persons are we are putting the persons randomly into the placebo group. But if we did a baseline comparison of both the groups in terms of various socio-demographic characteristics, both the groups are comparable. There is no difference between both the groups. So both groups are looking that they have the similar type of anxiety intensities also, and they are very much resembling to each other in a socio-demographic characteristics also. So this is the comparison of outcome between the groups. One is showing the standard error bar showing changes in GAD-7, total IH, individualized homeopathy and placebo group. And second is basically related to the Hamilton anxiety rating scales. So in a primary outcome, we will discuss in result section also. This primary outcome which we kept in this, that is your GAD-7, we did not find any kind of significant results from homeopathy in controlling the generalized anxiety disorders. But in secondary outcome, that is physician assessed Hamilton anxiety rating scale. So there we found some positive results with the individualized homeopathy over placebo. So this is about the result of this particular trial. So as this is a pilot trial, so it's ensure feasibility of larger and definitive trials in the same setting in future. Although no clinical statistical advantages of individualized homeopathy over placebo in treatment of GAD at primary endpoint could not be detected, but still some promising or a positive directional results is seen with the blinded psychiatrist secondary outcome, that is your Hamilton anxiety rating scales. So in the last section, we will talk about the take-home message that we can took with this particular research project. That this is basically in a small external pilot trial, so nothing can be conclusive and nothing can be generalized to the society also. So we definitely need a larger definitive trial which that can be performed, and the results can be generalized to the societies also. And the second important thing that we can take up from this particular project, that because earlier there is no similar kind of research project is done, so because of that we could not be able to calculate the formal effect size, and due to that we cannot be having a statistically justified sample size which can be used for a definitive trial. But with this external pilot trial, if we took GAD7 for calculating our formal effect size, so these are the sample size that can be effectively used to conclude the study, and the conclusion drawn from these sample size can be easily generalized, and it is accepted to the evidence-based medicine or scientific society easily. So if you kept this GAD7, so 220 is the sample size that is required to run a definitive trial, and 96 is a sample size to run a definitive trial if you are keeping Hamilton Anxiety Rating Scale as a primary outcome. So another important thing, because this is a very short-term project that is related to the thesis or postgraduate thesis. So only centesimal scale is used in this particular trial, but in future pragmatic trial, we can use some other potencies also, especially the LM scale that is used in NIH very frequently. So might be because of a higher dynamization or low molecule in that, they may be having good results in generalized anxiety disorders also. So with this, I would like to give rest to my voice. Over to you, ma'am.
Very happy to see that PG theses are now being oriented towards proper guidelines of RCT. And thank you, Dr. Nitin. Very happy to see you here for your presentation. And I would request Dr. Bipin Jain to give his comments and ask questions on the presentation.
So as we have only half an hour left, and we already have two more speakers to give their presentation, I would request you to keep the questions and the answers very brief.
Very, very brief. Last, only one question to him.
Yes, sir.
How did you take care of the biases and variations in physicians who are taking cases and prescribing, especially in psychiatric cases?
Okay, sir. Biases, actually we used because the psychiatrist is involved in this particular study, he used to label the subject with this particular diagnostic term. And the second biasness that comes when the different physicians are dealing is related to the homeopathicities of the drug, whether it's completely individualized homeopathy or not.
Yes.
So that is taken up care by a research publication that has already happened by the Robert Matthew, which this paper is called as Model Validity of Homeopathic Treatment, which help in keeping the prescription as far as possible homeopathically. So there is a various domains under that will help you in understanding whether this selection is purely on the basis of individualized homeopathy or not. So that particular criteria is basically used in order to understand that whatever be the prescription being a physician is doing, whether it's a basically biasness of his or a favorite medicine of his, or it is a purely with the concepts of the homeopathy. So that particular criteria we use to check over this self predilection to certain medications. So we just kept over this and we focus over this particular, so that our prescription will not be biased in any cases.
Okay, no issue. You can go ahead. So I will limit my questions to this only. Go ahead.
Thank you. Our next speaker is Dr. Swapan Paul. I invite him to present his research study on individualized homeopathic medicine in the treatment of tinea corporis, double-blind, randomized, placebo-controlled trial. Over to you, Dr. Swapan Paul.
Thank you, ma'am. Good morning to all the national and international dignitaries connected in this session. Myself, Dr. Swapan Paul, Assistant Professor, Department of Medicine Medica, National Institute of Homeopathy, takes this opportunity to present a study on efficacy of individualized homeopathic medicine in tinea corporis, a double-blind, randomized, placebo-controlled trial. So I am going with my presentation right now. Okay, it's moving right now, right?
Yes.
Yeah, thank you. So this is my study designed that efficacy of individualized homeopathic medicine in tinea corporis, double-blind, randomized, placebo-controlled trial. Here is the list of contributors who involved in this study. Baki Billah Lashkar is one of my PGT. He has taken much effort in this study. Regarding this tinea corporis, this introduction is that tinea corporis is a ringworm. Generally, it is termed as it's a dermatophytosis. It's a superficial skin infection affecting mainly the keratin or epidermis, hairs, nails, after direct contact to the infected soil, animals or the skins or the other humans, mainly caused by the microsporum, epidermophyton, and trichophyton genera of the dermatophytes. Worldwide prevalence of the superficial mycotic infection is 20 to 25%, with lifetime risk of developing the infections estimated to be 10 to 20%. In rural India, the prevalence rate of tinea corporis is 78%, whereas in Kolkata, it is effective rate is 86%. The fungal infection of the tinea and its appendices, this is this fungal infection of the skin and its appendices include tinea, which is common in tropics. That is, in tropical countries, this kind of infection is more like India. Patients presenting with widespread atypical and symptomatic lesions of tinea corporis infection, and it requires a prolonged treatment. This study was undertaken to evaluate the efficacy of individualized homeopathic medicine in LM potency against placebo in treatment of tinea corporis. The aims and objectives of the study was to detect the efficacy of individualized homeopathic medicine in treatment of tinea corporis, and the objective was to evaluate the group differences in number of patients in each group showing complete disappearance of the skin lesion over 3 months of intervention, to evaluate the group differences in 0 to 10 NRS intensity of itching, that means numeric rating scale, and Skindex 29 questionnaire scores. And another objective of the study was to shortlist the most frequently indicated medicine in tinea corporis with their indications. The study design was, as we have already said, that double-blind randomized placebo-controlled trial, 2 parallel arm clinical trial was done. A study was done at National Institute of Homeopathy, and in between the period of November 2019 to March 2021. The sample size, the formal sample size calculation was not possible on account of absence of any earlier study of the similar design. So we expected that complete disappearance of tinea will be in 50% of the patient in Veram group and 25% of the patient in control group. Calculated effective size was 0.5 and accounting for an expected attrition rate up to 20%, assumption of effect size 0.5, and in order to detect a significant difference between 2 proportion over 3 months of interventions through chi-square goodness of fit 2/2 coincidency table. A study with 2 arms. In each arm, 31 patient was considered. That would give 95% power based on 2-sided significance level of 5. Materials and methods of this study was randomization was done. A randomization sequence was generated by permuted block randomizing, maintaining 1:1 allocation by an independent third party in the strict confidentiality using the strict random number generation and made available to the blinded pharmacist in coded form for dispensing from the coded vials as per the prescription. Blinding. Double blinding method was adapted by quadruple masking, that is masking of patients, investigators, outcome assessors, and data entry operators throughout the trial. Allocation concealment was maintained by identical coded vials, coded as 1 or 2 and containing either of the medicine or placebo, and codes were assigned randomly and confidentially by a third party. The materials and methods section, ethical issue was considered as approval from institutional ethical committee, and prospectively the trial was registered in CTRI, and the trial was in compliance to Helsinki's declaration for ethical conduct of clinical trial involving human participants, International Conference on harmonization guideline for good clinical practice. Then provision was kept in the protocol to treat the intercurrent illness, adverse or serious adverse event, if any, as per the homeopathic principle or as per the referral. No new drug has been proved here. No new treatment protocol has been adapted in this study. Patient information sheet and written consent was taken prior to the enrollment of the patient. Inclusion criteria was in between, the age group was in between 18 to 65 years, suffering from tinea corporis as per the ICD-10 classification. Literate and willing to give written consent patient was considered. Washed out period of 2 weeks for patient using topical agent was there. Exclusion criteria was complicated with lichenification and eczematization and similar conditions like seborrheic dermatitis, pityriasis, rosacea, or psoriasis that was not been considered. Unstable mental or psychiatric illnesses or other life-threatening illnesses, if the patient is suffering from, not been considered. Receiving homeopathic treatment for any other chronic conditions within last 6 months has not been considered in the study. Self-reported immune compromised state, if it is there in this patient, not been included in the study. Pregnant and lactating mother has not been included. Substance abuse or dependence patients has not been considered for this study. Intervention was experimental group received individualized homeopathic medicine in LM potency, and control group received identical looking placebo medicine. And concomitant care like maintenance of hygienic measures was being considered for both the groups. Outcome measures was under 2 different heads. Number 1, primary, and second one is secondary. Primary outcome measures was number of patients in each group showing complete disappearance of the skin lesion over 3 months of intervention. Then secondary group, number 1 was 0 to 10 NRS measuring intensity, that is numeric rating scale of pruritus represents the numbers 0, that is no itch, to 10, that is worst imaginable itch that can happen in the patient. Second one is Skindex 29 questionnaire, health related quality of life considering degree of symptoms, that was 7 items. Then psychiatric functioning, psychological functioning, it included 12 items, and emotional status, it included 10 items. That questionnaire was being adapted for secondary evaluation. Then statistical analysis was taken, like intention to treat approach was adapted by replacing missing values with regression to the means. The intra-group changes were examined using one-way repeated measures analysis of variance. Inter-group differences were tested with chi-square test, unpaired t-test, two-way repeated measure analysis of variance test. Reporting guideline was adhered to consult extension statement for randomized trial, as well as red hot guidelines for reporting trials. This is the flow diagram of patient inclusion. This is a consult as per the consult flow diagram. Screening was done in this study of 98 patients, and 36 patients were excluded for different reasons, like the patient illiterate could not give the written consent, or the patient could not follow the questionnaires adapted for this study. The patient denied for giving consent and already undergoing homeopathic treatment. Ultimately, all the criteria met by 62 patients for our study, and 2 arm was there, received individualized homeopathic medicine that included 31 patients, and received placebo of identical placebo, that is of 31 patients. And among this Veram group, that is individualized homeopathic medicine group, we lost 3 patients. The reason was could not be contacted further, discontinuation due to medical reasons, and discontinued due to COVID lockdown period. And 31 patient in placebo group, we lost 2 patients, but they did not report it again, and that discontinuation due to some other reasons like lockdown period or like that, so they didn't report it to our study. Then followed up every month until 3 months, 28 patients, and in this placebo group 29 patients were followed up. But at the end of the analysis, at the end of the study, analysis was done all 31 patients for both the groups, that is individualized homeopathic group as well as for the placebo group. The results was like that. Primary outcome, complete disappearance of the skin lesion over 3 months of intervention was observed in one patient, that was in placebo group, and thus no significant group difference could be detected as a primary outcome. And in secondary outcome, in itching this NRS scale, that is numeric rating scale, intra-group improvement over time was significant in both the individual homeopathic group as well as in the placebo group. Skindex 29 questionnaire. In that outcome, intra-group changes over different points of time of several of overall score and all subscale scores were statistically significant in both the groups. And intergroup difference in overall score, 2 subscores over 3 months of intervention significantly favored the individualized homeopathic medicine against placebo. And this is the result of secondary outcome measures, that changes in the mean pruritus intensity score over different time points in 2 groups that has been presented graphically in this diagram, in this slide. And another was changes in the mean Skindex 29 total score over different time points in 2 groups has been given here. And this is the medicines which are frequently came to in the prescription, starting from sulfur, basilinum, thuja, calliers, tellurium, lycopodium, natramur, pulsatilla, then lachesis, sepia, arsenica verbum, iodine, soranum. These were frequently prescribed medicine. The strength of this study was, the study design was a double-blind RCT, followed consult guideline using LM potencies, validated outcome measures like NRS, that is numeric rating scale, Skindex 29, DLQI, were used to assess the clinical symptoms and quality of life as the secondary outcome, further strengthen the trial. Limitation was sample size could be a constant. With this small sample size, nothing can be concluded. And the future study, rigorous trial and independent replications are warned before making any firm recommendation about this study. The conclusion about this study is that in this double-blind RCT conducted on 62 patients suffering from tinea corporis, no significant group difference could be detected on the primary outcome, that is disappearance of the skin lesions over 3 months of trial or 3 months of interventions. However, the secondary outcome revealed statistically significant improvement in the individualized homeopathic group in comparison with the placebo, and further independent trial are warned for any conclusive recommendation about this study. So here is the reference listed. Thank you all for attending this presentation and for giving me opportunity to present my this study on this efficacy of individualized homeopathic medicine in tinea corporis. And once again, I'm thankful to the organizer for giving me opportunity for presenting my study. Thank you, sir.
Thank you, Dr. Swapan Paul, for your interesting study and lucid presentation. I would now ask Dr. Bipin Jain to give his comments.
And I will not go into much of a detail. Only one question.
Yes, sir.
How was the care was taken about the seasonal variations, hygiene, and a patient with diabetes mellitus when we are dealing with the tinea corporis?
Yes, sir. Actually, in case of diabetes mellitus, this patient, non-diabetic mellitus, because they are already taking any kind of previous medicines. So in my exclusion criteria, it is mentioned that any kind of treatment is taken by the patient will not be included in the study.
So any kind of means any allopathic treatment, or you are saying any systemic disease which influence the outcome of tinea corporis?
Yes, sir. Any systemic diseases, any kind of this diabetes, thyroid, all these kind of.
So we need a little clarification at that level. And another thing is your hygiene and how did you take care of seasonal variations? because humid and hot compared to dry winters, it does have variations in tinea.
Yes, sir.
So how that care was taken in your trial?
Sir, I think we have missed that point regarding the seasonal variation. We can include for the further study also.
And hygiene advice for hygiene.
Yes, sir. Actually, we had advised the patient that any kind of these hygienic measures like clean skin should be maintained, clean clothes to be maintained. Then any kind of this woolen clothes which can interfere with the skin problem, that should be avoided. So cotton clothes could be used. So that kind of measures are taken.
That also should be mentioned so that the people who are reading or listening will not have those
Yes.
aspects in looking at your scientificity of the whole study.
Sure, sir.
Thank you.
Thank you so much. Thank you, sir.
I'm doing my job very swiftly, shortly. You can
Thank
go
you,
ahead.
sir. Now we have our last presenter for today's session, Dr. Shraddha Khanna, to present the response of individualized homeopathic medicine in the treatment of hypothyroidism using Zaleski's clinical score. Over to you, Dr. Shraddha.
Thank you so much, ma'am, for inviting me. Ma'am, I'm audible?
Yes.
Okay. Good morning to all the respected panelists, the chairpersons, and the delegatories. Myself, Dr. Shraddha Khanna, Assistant Professor from Baxan Homeopathic Medical College and Hospital. Today, I'm going to present a paper on response of individualized homeopathic medicines in the treatment of cases of hypothyroidism using Zaleski's clinical score, a prospective, open-label, non-controlled observational trial. Hypothyroidism is one of the most common thyroid disorders in India, with majority of cases occurring in women and elderly. Treatment of clinical and subclinical hypothyroidism is determined by the physician's assessment of the clinical severity of the disease. A symptom rating scale like Zaleski's clinical score is thus necessary to assess the clinical status. In our study, we have assessed the response of the medicines in the treatment of hypothyroidism using the Zaleski's clinical score. Thus, besides TSH and thyroid hormones, parameters such as angle reflex relaxation time, which are known to reflect the tissue manifestations of hypothyroidism, were also measured. The research question was, if individualized homeopathic medicine is effective in producing any significant change in thyroid profile and the symptom picture in cases of hypothyroidism. The null hypothesis which was considered was that there will be no change in the thyroid profile and symptom picture even after 6 months of individualized homeopathic treatment. And the alternative hypothesis which was considered was that there will be significant change in the thyroid profile and symptom picture in patients suffering from hypothyroidism after 6 months of individualized homeopathic treatment. The objectives which were to be completed were, first one, to assess the changes in Zaleski's clinical score for hypothyroidism and to assess the change in thyroid profile in patients suffering from hypothyroidism. Materials and methods. The study was carried out in the National Institute of Homeopathy, Kolkata, India. The source of the samples were patients visiting the outpatient department of the institute. A total of 57 patients having hypothyroidism and fulfilling the Beloeck's diagnostic criteria were treated by individualized homeopathic medicines for a period of 6 months. Regular follow-ups were done as per the need of the patients to ascertain whether there was progressive improvement and whether it was sustained or not. Patients' response was evaluated by changes in Zaleski's clinical score and serum thyroid hormone levels as the primary outcome measures, and thyroid symptom questionnaire scores as the secondary outcome measures from baseline to 3 months and 6 months. The participants were included on the basis of certain criteria, such as newly diagnosed cases of hypothyroidism with serum TSH levels more than 4.25, who were fulfilling the Beloeck's diagnostic index criteria, belonging to age group of 18 to 65 years, literate patients who were able to read and write in Bengali, English or Hindi, patients who had given written consent to participate. And the patients were excluded on the basis that patients who were undergoing levothyroxine sodium therapy for hypothyroidism or TSH levels were above 10, patients who suffered from congenital hypothyroidism, or those who were having psychiatric diseases, pregnant females and lactating women, and cases who suffered from any other uncontrolled systemic illness or life-threatening infections. Statistical techniques and data analysis. Every patient included in the study was entered in the final analysis. Missing values were replaced by series mean or multiple imputation technique. Analysis was done with the help of pictographically and other standard statistical methods. Statistical analyses were carried out after data collection for both descriptive and inferential statistics. ANOVA single factor test has been done to analyze the response of medicines administered from baseline till 3 months and 6 months. These are the observational results. This is the flow diagram, how the screening was done. About 76 patients were screened according to the eligibility criteria, and of which 19 patients were excluded for the reasons such as few were illiterate, few were already taking levothyroxine therapy, and few of them were having uncontrolled hypertension and diabetes mellitus. So overall, 57 patients who met the eligibility criteria were enrolled, and they received the individualized homeopathic treatment, of which 3 patients were lost to follow. So overall, 54 patients were there who completed the study. Descriptive statistics. 4 variables were studied: age groups, gender, BMI, and comorbidities. The maximum number of patients which were enrolled fall under the age group of 30 to 39 years, about 31.58% of patients. Maximum number of patients, about 85.96% patients were female. And maximum number of patients were having normal BMI. They fall under the category of normal BMI, having BMI in the range of 18 to 25, about 57.89% of patients. The comorbidities which were associated with the patients were like allergic rhinitis, cervical spondylosis, eczema, headache, hypertension, low backache, palpitation, polyarthralgia, and others. The medicines prescribed in cases were like Calcarea carb, Calcarea phos, Carboveg, China, Calibai, Laccan, Lachesis, Lilium tig, Nux vomica, nitric acid, sepia, and sulfur. Out of these, the frequently prescribed medicines were sulfur, given in 8 cases, Natrum muriaticum, given in 7 cases, Calcarea carbonicum, given in 7 cases, and sepia, given in 6 cases. And the less frequently prescribed medicines were like Calcarea phos, Laccan, Calibai, Lilium tig, nitric acid, and Suraimum. Inferential statistics. One-way repeated measures ANOVA compared all the readings. Values showed statistically significant improvement in the Zaleski's clinical score, thyroid profile, and thyroid symptom questionnaire. Zaleski's clinical score is a clinical scoring system based on the presence and absence of hypothyroid signs and symptoms. It includes about 7 symptoms like diminished sweating, hoarseness, paresthesia, dry skin, constipation, impairment of hearing, and weight increase, and 5 signs like slow movements, delayed ankle reflex, coarse skin, periorbital puffiness, and cold skin. A score of 5 or more is diagnosed to be having hypothyroidism, and a score of 0 to 2 is considered to be patient to be euthyroid. So we noticed that the mean value of Zaleski's clinical score drastically changed from 6.14 to 3.77 over the period of 6 months from the baseline. The mean value of serum T4 increased from 7.46 to 8.47 from baseline to 6 months. Mean value of serum T3 increased from 1.13 to 1.53 over the period of 6 months. And mean value of serum TSH decreased from 7.73 to 4.64 over the period of 6 months. The thyroid symptom questionnaire score also decreased from 5.74 to 3.98. Discussion. Socio-demographic findings. In the present study, the maximum number of patients who were suffering from hypothyroidism belonged to 30 to 39 years of age group, whereas commonly it is seen that hypothyroidism is a disease found in elderly population, that is above 60 or above 80 years of age. Hypothyroidism commonly occurs in women more than men, and the same was found in the present study. While hypothyroidism is commonly associated with obesity, patients in our study were having normal BMI. The commonly associated comorbidity in our study was low backache, and reason for this association may be that large number of persons who were reporting to NIH complaint of low backache. Also, there are studies according to which hypothyroidism may be associated with muscular weakness, pain, and stiffness. The principal findings were that there was statistically significant reduction in the values of Zaleski's clinical score, statistically significant increase in serum T3 levels and serum T4 levels, and statistically significant decrease in serum TSH levels. Also, the thyroid symptom questionnaire scores achieved significant reduction over 3 months and 6 months of treatment from baseline. While 2 cases showed increase in this clinical scoring, 1 case showed no change in the score, and rest of the cases showed significant improvement. There were 2 cases which showed increase in TSH values, and 9 cases which did not show marked improvement in the TSH values over the course of 6 months. Rest of the cases showed significant improvement in TSH values. Cases which showed increase in TSH levels also showed increase in clinical scoring. This shows that the patient was not better symptomatically also. Medicine used in these cases were pulsatilla and lacazettes. Thus, it is clear from the above discussions that the clinical picture of a hypothyroid patient may not always correlate with the TSH levels. These are few of the cases which have showed marked improvement. Case number 4, in which the TSH levels went from 9.67 to 3.45 over the treatment over the course of 6 months, and the clinical scoring went from 7 points to 5 points. The medicine prescribed here was nitric acid 200 in 1 dose, and only in between the treatment, only Aconite was given at about third month for some intercurrent illness like cough and cold, which the patient was suffering. The base of prescription of nitric acid 200 was the hard stools at 2 days interval, dreams of death of relatives, angry during headache, iron contradiction. Case number 18, the TSH values went from 9.8 to 4.64, and the clinical scoring went from 5 points to 4 points. The medicine prescribed was Syncona officinalis 200 1 dose at baseline, and it was repeated at 3rd month. The basis of prescription were excessive flatulence, bloating, eructations giving no relief, pain in whole body ameliorated by heart pressure. Case number 24, the TSH levels were 9.02, which went down to 3.71, and the clinical scoring went from 8 points to 4 points. The medicine prescribed here was again Syncona officinalis 200, 1 dose at baseline, and again China 1M was repeated at 3rd month. The prescribing symptoms were flatulence with heaviness and abdomen, aggravated after meals, undigested stools, loose and offensive stools. Case number 33, the TSH values went from 10.01 to 3.45, and the clinical scoring went from 7 points to 5 points. Here, CPR-1M was prescribed in 1 dose. The symptoms of prescription were pain in both the knee joints, aggravated in night and rainy season, low backache, history of strain, 10 to 12 days back while doing laundry. Case number 38, the TSH value went from 9.64 to 2.91, and the clinical scoring went from 5 points to 3 points. The medicine prescribed here was sulfur 200 in 1 dose, and the symptoms were pain in multiple joints of body, aggravated at rest, night, ameliorated by stretching, hard stools, has to strain a lot, and pass daily early morning. Case number 47, the TSH levels went from 9.15 to 4.73. Clinical scoring went from 10 points to 4 points. And here also the Natrammu 200 was prescribed in 1 dose only. And the main symptoms were headache with burning sensation over the vertex, aggravated from sun heat, and ameliorated by sleep. And obviously the medicines were given only after considering the totality of symptoms. These are only the key indications. Conclusion. Individualized homeopathic medicines are not only capable of decreasing the TSH levels significantly, but also in making the patient symptomatically better. Thus, a null hypothesis gets rejected. Also, careful attention must be paid towards wider employment and usage of Zaleski's clinical score, as it highlights the concept of tissue hypothyroidism giving an easy method of assessing the severity of a case. A patient presenting with the signs and symptoms of hypothyroidism may not always be diagnosed biochemically hypothyroid. Therefore, not to miss such a case and prevent them in developing into overt hypothyroid, the scale appears to be a very helpful tool. Thank you so much.
Thank you, Dr. Shraddha, for your presentation. I would ask Dr. Bipin Jain to give his comments on the presentation.
There are 2-3 quick comments. One is you have not diagnosed hypothyroidism and the cause-wise, because a lot of immunological perspectives when we are talking of Hashimoto's and Graves' disease and maybe and subacute thyroiditis, which finally land into hypothyroidism. So that classification is not there. Since it is an observational study, so I will not much give stress on it. Second is the impact of stress on hypothyroidism is quite great. So, dealing with patient and counseling by itself can change the thyroid level. So that aspect also probably is, missing, which could have been taken care of with this. The third is during menopause. You have a second large group of menopausal females, right? And during menopausal period, the thyroid levels are known to fluctuate and settle down by their own. That's a third variables which should be looked into when you are going for a larger trials. I'm just giving you the input for the larger trials, since yours was just an open label, preliminary or primarily. I would put it as a pilot project to look into whether homeopathic has got any effect on hypothyroidism from those perspectives. And the only thing which I did not understand is why did you limit the question is TSH to level 10 only, and why you excluded cases beyond 10?
So, because it may have been difficult to handle cases with only the medicines. The patient may have presented with symptoms which may not have been able to be managed by the medicine. So we have kept it in that much range.
So on what basis or on what study you came to this conclusion?
So on the basis of the previous studies.
I mean, you have not stated those studies.
So
we are limiting ourselves based on an individual perception, and which should not be done in an inclusion and exclusion criteria.
So actually the clinical scoring was used. So that too, we have to diagnose the patient symptomatically. So for that case, the patients with less means not having much of the TSH levels needed to be enrolled.
Because these TSH fluctuations are known to settle down many times by their own. So until you have a, titers, the immunological assays like microsomal antibodies, thyroid and thyroid the antibodies, thyroglobulin. So all those, so that would have given a further strength to the study. But no issue. It was a good study, and we can work further. Okay. Thank you, Dr. Matthew.
Thank you so much, sir, for your inputs.
Thank you, Dr. Shraddha and Dr. Bipin. I would, as a summary, I would request Dr. Bipin to give his conclusion regarding or these findings regarding the whole session in part.
I think it was a wonderful experience to go through RCTs. RCTs in homeopathy are being perceived in a different way. So I like the way things have been taken up with the individualized homeopathic medicines against, with the placebo or open label or, double blind, single blind. So, I mean, if we take up such study, it will definitely open up a lot of scientific pathways to prove that, yes, homeopathy is effective beyond, what people think, because we have limited ourselves. That's what I was asking to the last presenter, that why did you limit to the 10? I mean, what was it which was not allowing you to go beyond? But then all the studies have been path breaking, and they are looking at the things from a real scientific way. It's not, just I saw, I gave, I treated, and I thinking that patient never came back because he was all right. So now we are moving to more scientific way of looking at our results, which will be more convincing not only to our colleagues but to the outside scientific fraternity. So all the presentations I would have taken a care in terms of bringing in maximum scientificity and followed a basic research methods as well as statistical outcome. So I mean that gives, and I'm really happy to be part of this presentation and being invited as a chair, because I have also learned a lot by listening to this, and probably this will also give me further opening to do more research in a different areas, including materia medica. So thank you, and I hope that we will hear from all the presenters in future about the larger samples and a better outcome and a structured guideline to manage all the conditions which they are working with. Thanks.
Thank you, Dr. Bipin, for your wonderful summary of this session. I think we had an awesome session on RCTs. Now I'll hand over to Dr. Anu for the concluding.
We have come to the end of our forenoon session. I wish to extend my sincere gratitude to our Honorable Chairperson, Dr. Bipin Jain, for his valuable inputs and comments. I thank all the presenters for their wonderful presentation. Thank you all the delegates and organizers of the team